Welcome to the module on Introduction to Neuropsychiatric Syndromes for the Nurse Practitioner. My name is Melody Harris. I'm Associate Professor at the University of Arkansas for Medical Sciences, and I'm recording on behalf of the Gerontological Advanced Practice Nursing Association. In this module and throughout this series, the term persons living with dementia will be used to emphasize that dementia is a diagnosis and does not define the individual. This is to emphasize person-centered care because dementia is a highly stigmatized disease process. The purpose of this module is to discuss the definition and measurement of neuropsychiatric syndromes related to memory care. First of all, it is important to know the differences between neuropsychiatric signs, symptoms, subsyndromal conditions, syndromes, and disorders. The following definitions are taken directly from the glossary of technical terms in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. There is a difference between age-related changes, neuropsychiatric symptoms, neuropsychiatric syndromes, and mental health disorders. Age-related changes are not pathological and are not signs, symptoms, or syndromes of a mental health disorder. Although there are age-related changes in memory, such as the speed of recall and learning, these are not symptoms of dementia or a mental health condition. Standard terminology and measurement tools are needed to determine neuropsychiatric symptoms. A sign is an objective manifestation of a pathological condition. Signs are observed by the examiner rather than reported by the affected individual. One example of a sign of Alzheimer's dementia is memory loss. Typically, signs of a disease such as Alzheimer's dementia may be mild and then progress to a moderate and then severe phase. It is important to remember that there are age-related changes in memory, such as forgetting a name, but remembering the name later, or misplacing an item, but then finding it later. It is the frequency and disruption in activities of daily living that determines the pathological condition that requires treatment. A symptom is a subjective manifestation of a pathological condition. Symptoms are reported by the affected individual rather than observed by the examiner. An example of a symptom of dementia is observed if a patient were to say something such as, "Last night, there were 3 robots in my house trying to steal my purse." Behavioral and psychological symptoms of dementia, or BPSD, is a common term that is defined by the International Psychogeriatric Association. A syndrome is a grouping of signs and symptoms based on their frequent co-occurrence that may suggest a common underlying pathogenesis, course, familial pattern, or treatment selection. Researchers are studying neurodegenerative diseases, genetics, and pathology in association with neuropsychiatric syndromes. Neuropsychiatric syndromes are clusters of symptoms. Neuropsychiatric syndromes are specific to the disorder. For example, depression and psychosis are specific to Parkinson's-induced dementia. Researchers use the term agitation along with apathy and depression to cluster symptoms that are included in neuropsychiatric syndrome for Alzheimer's dementia. The importance of recognizing specific neuropsychiatric syndromes is to provide the appropriate treatment options. Citalopram has been found to treat neuropsychiatric symptoms termed as agitation and depression in Alzheimer's dementia. Dementia is not a normal part of aging. According to the DSM-5, a dementia subtype such as Alzheimer's dementia or vascular dementia is a neurocognitive disorder. A mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the physiological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. An expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. Socially deviant behavior, such as political, religious, or sexual, and conflicts that are primarily between the individual and society, are not mental disorders unless the deviance or conflict results from a dysfunction in the individual, as described above, as previously described. Alzheimer's dementia is an example of a major neurocognitive disorder. Standardized terminology and measurement tools for neuropsychiatric symptoms are needed to define and identify neuropsychiatric symptoms. Measurement tools such as the Cohen-Mansfield Agitation Inventory, the Behavioral Pathologic Rating Scale, Cambridge Behavioral Inventory, the Pittsburgh Agitation Scale, the Scale for Observation of Agitation in Persons with Dementia of the Alzheimer's type, and the Neuropsychiatric Inventory are tools to measure neuropsychiatric symptoms. The International Psychogeriatric Association has categorized neuropsychiatric symptoms as behavior or psychological. Before 1999, the term behavioral disturbances were used to describe neuropsychiatric symptoms. By consensus, the International Psychogeriatric Association replaced behavioral disturbances with behavioral and psychological symptoms of dementia, or BPSD, defined as symptoms of disturbed perception, thought content, mood, or behavior that frequently occur in patients with dementia. Symptoms are categorized as behavioral or psychological. According to the International Psychogeriatric Association, physical aggression, wandering, restlessness, and agitation are examples of behavioral symptoms. Anxiety, depression, hallucinations, and psychosis are examples of psychological symptoms. Other organizations and experts, such as the European Alzheimer's Disease Consortium, also defined neuropsychiatric symptoms. The terms agitation and aggression are often used interchangeably. The Neuropsychiatric Inventory combines agitation and aggression. The Cohen-Mansfield Inventory recognizes verbal and physical aggression. The overlap between agitation and aggression has been recognized by researchers and professional organizations. About the same time as the International Psychogeriatric Association definition of behavioral and psychological symptoms of dementia, Hurley and colleagues defined agitation as an unpleasant state of excitement experienced by the patient with dementia of the Alzheimer's type. The theoretical operational definition, those observed patient behaviors that communicate to others that the patient is experiencing an unpleasant state of excitement and which remain after interventions to reduce internal external stimuli by managing resistiveness, alleviating aversive physical signs, and decreasing sources of accumulated stress have been carried out. Consensus groups from the International Psychogeriatric Association further defined agitation, and more recently, psychosis was defined. This work is meant to be evolving and changing to keep up with the research. According to the International Psychogeriatric Association, agitation is broadly defined as occurring in patients with a cognitive impairment or dementia syndrome, or exhibiting behavior consistent with emotional distress and or manifesting excessive motor activity, verbal aggression or physical aggression, and experiencing behaviors that cause excess disability and are not solely attributable to another disorder, whether it be psychiatric, medical, or substance use related. Agitation occurs within the sphere of the person living with dementia, and aggression involves interaction with others. The International Psychogeriatric Association views aggression as a more severe form of agitation. Although terms agitation and aggression are widely used clinically and in research, Perhaps these terms should not be used at all. Terms such as agitation, aggression, and behaviors have a connotation of intentionality, when in fact, those expressions are a symptom of a disease process, similar to an elevated blood pressure or creatinine level. Standard terms and measurement tools are important because dementia is already stigmatized. The American Psychological Association revised the DSM-5 to categorize dementia as a neurocognitive disorder. The term dementia is still used, but this is a new change in terms that was meant to level the playing field for persons living with dementia. Although stigma has a tendency to perpetuate, this is a start. In summary, neuropsychiatric symptoms occur in almost all persons living with dementia. Recognizing symptom clusters and neuropsychiatric syndromes associated with neurodegenerative disorders provides a systematic approach to treatment. Standardized operational definitions and person-centered terms are needed to navigate a high level of care for persons living with dementia. More research is needed to develop measurement tools for neuropsychiatric syndromes. Now is the time for educators, researchers, clinicians, and journalists to make innovative, cutting-edge contributions towards models that can be replicated for the highest quality care of persons living with dementia and neuropsychiatric syndromes.